All right. So again, thank you for joining us in our maternal infant health series. Today we have Amy Langenfeld, who will review the opioid use disorder in pregnancy, beyond the stigma to evidence-based treatment. As we begin, I do want to just introduce you guys a little bit to the maternal infant health series, and thank our partners, DHS, for also sponsoring this event. If you are not familiar with Wayside Recovery Center, we have been providing services, gender-specific services for over 60 years, specifically in substance use disorders and mental health. We are trauma-informed based, and we really stand for providing culturally specific care through family services, dedicated to providing wraparound services to the women and children, and also the families that we serve. We specialize in empowering women and breaking generational cycles of substance use. Now I'll introduce Amy Langenfeld. She is a highly experienced healthcare provider working with at-risk communities in the Twin Cities for nearly 20 years. She is recognized widely as a leading expert in opioid use during pregnancy, specifically as it affects populations facing disparities in urban and rural settings. Amy attended the U of M for both undergrad in nursing and also her grad school in midwifery. Amy has completed her education for psychiatric mental health nurse practitioner certification and will be sitting for the National Certification Board shortly. Congratulations, Amy, on that, and good luck also. Amy has also been featured in documentaries and webinars and interviewed on radio regarding her work with pregnant opioid-dependent women. Amy's clinical work is predominantly been with inner city populations that see sexual violence and drug use disorders at a much higher rate than national average. She has worked daily with women and families who have experienced multi-generational sexual violence, human trafficking, drug and alcohol dependence. She is a clinic specialty of opioid use in pregnancy and has a Suboxone and is a Suboxone provider. So with that, a ton of experience, we are definitely excited to have you join us today and present this wealth of knowledge that you have and this information, Amy. So with that, I will turn it over to you. And before we do begin, I do want to encourage you all to drop questions in the chat as you get this information, and hopefully we'll have some time at the end to also answer those questions. All right, Amy, over to you.
Thanks so much. I just want to report back that I sat for my boards, past boards, and so now I'm a licensed psychiatric mental health provider. So that's super exciting. I know, yay! It is, yeah, it was a journey. So I do want to say thanks to everybody here. I've been speaking around this topic for many years, and the pandemic has put us into this Zoom land that is superbly disorienting for me. I love to see the room. I love to see who's here, and can, kind of get that verbal and nonverbal feedback so I can kind of, give you what you're looking for. So please do not hesitate to drop a question in the chat box if you have it. If I'm going in a direction that just is not beneficial or helpful to you, please don't hesitate to speak out. We have a really diverse audience today, and so we're going to see what we can do to meet everybody's needs. So I probably have more slides than we need, so I'm going to try to kind of bump through them. I do speak pretty quickly, if you haven't noticed that already. So if I'm talking too fast, again, let me know what you are needing. So here we go. So disclosures. I do not have any financial disclosure. This information that I'm giving you today is really a combination of others' research. I am not a researcher. I am a clinician, but also my clinical experience. No financial gains. And I think it's important just for everyone's protection that the opinions shared in this presentation are mine and do not reflect anyone on my employers. So language, I think that we can just touch on this, the DSM-4 versus 5. The language went from addiction to substance use disorders. I try to use substance use disorders. Some of my data, some of my information is DSM-4 era. So it may still have some of that old language. And then MAT. I really just want to challenge everyone to think about if we are using this medications. So we're using medications to treat addiction or substance use disorders. And so is MAT really truly medication assisted treatment, or is it medication for addiction treatment? I'm going to push on the second one because I think that the medications that we'll talk about and what will hopefully come to light is that we are treating a chronic disease, and we are not adjunct to traditional talk therapy. So the things we'll talk about today, we're going to differentiate the approaches to providing care to pregnant women with opioid use disorder, the comorbidities around that, and then discuss what is the safe care of these women. Why we're talking about it, I think we all know this is on the rise. It's a threat, it's a threat to everyone, but it's, as well as pregnant women and children, both unborn and born. Also, the care and treatment of the pregnant opioid dependent patient really can be very counterintuitive to most, well, it is very counterintuitive to most patients, but I think we still have a certain amount of clinicians who are really struggling with what they actually safe care is. I got stuck, sorry. And then this epidemic, really, I'm so glad you're all here because this epidemic is growing at a rate that we cannot medically and societally just keep pace to. When I started talking about this, I'm trying to think about how long ago it was, I was like one of the first people to really be banging the drum on, we have to treat these women appropriately. And I'm going to stop there because we'll come up with it later. So just a little bit of data, because I love data. It's one of my favorite things in the world. This is the drug overdose mortality rates by race and ethnicity. So you can see that everybody, all of the studied races here and ethnicities have had a significant increase, but the American Indian, Alaska Native overdose deaths have just outpaced everyone. I have a lot of my information is around American Indian data because that is the population that I have traditionally worked in. I also like to share that data because it's reflective of almost every other population. It's just the scale is larger, the percentages are larger. So for example, the increase of admissions by gender. This is the American Indian data, but if you look at Caucasians, you're going to see the same kind of trend. So I think it's really important that we know that this is impacting women at a much higher rate. And we will talk about that, like why is it affecting women at a higher rate briefly in a little bit here. And I do apologize that my data is not, some of it's not fully up to date. Getting data, very specific data has been a challenge, which that I'm still working on. But this is, these trends are consistent. And American Indian, so here is also the admissions by age. And I think it's really important to note that 82% of these women who are being admitted for treatment are for heroin specifically are of childbearing years, right? So this population is very much at risk. Pregnant women entering treatment, just the gross numbers as well as the opioid numbers. So the gross numbers I was able to get, unfortunately, the opioid I've not been able to get that, but we can see, that it was a continued trend until about 2018. And now fewer women are entering treatment. And I do want to talk a little bit later about why that's probably happening and what our role in that is. There was a shift in admission rates in about 2012. This is the data on the pregnant women, but this is almost exactly the same trends in every other population. That the opiates, which are going to be the pharmaceuticals, and the heroin, right? This is pre-fentanyl rage. But what happened is, you can see in about 2012, is that the PMP went into effect. And so we've done a really good job, I think, at tampering down some of the illicit pharmaceutical use. But unfortunately, heroin was just standing in the sidelines, waiting to, take the place of anything else. In the brain, it doesn't care which opioid it uses. It wants the opioid. And so when we really pushed down on the pharmaceuticals, the illicit use of the heroin increased. I like this slide because it shows, I think, a really important thing that we can all kind of take home. So the primary drug of abuse for pregnant women historically has been alcohol. But you can see from that obviously you can see the trend of the decrease. And I would like to propose that this is from the March of Dimes, that the March of Dimes has done such an amazing job at educating patients and clinicians about the dangers of alcohol in pregnancy. And I show you this slide because I think we can do the same thing around opioids. And I actually think we are doing the same thing around opioids. And I think that's why we're seeing maybe some of those decreases in the admission rates to treatment. I do want to really kind of hammer this home. One of the things that I always hear in clinic is about neonatal abstinence syndrome, or NAS, like the treatment of opioid use disorders. Is my baby going to be born addicted? But I do want to point out that NAS is not unique to opioids. So when we talk about it, I think we need to just remember that. Any drug, any chemical that a woman is using regularly during pregnancy can cause NAS. One of my biggest things, I'm just like stuck trying to grab this word here, the focus of care. I think that we really need to look at how we are approaching women with drug use disorders, or really all pregnant women, in their care. Are we focusing on the fetus, or are we focusing on the woman? When we focus on the fetus, there is this assumption that there is a suspension of all maternal need. I have worked in Latino communities for years as well, and the Latino word, or the Spanish word for like the Virgin Mary, or the Holy Mother Mary, is Guadalupe, right? So I always call this the Guadalupe syndrome, that there is this assumption that when women get pregnant, that Guadalupe comes down and they are totally embodied as being this holy vessel, and everything that she has ever struggled with or issues that she is having goes away just by magic. And I think this is just this cultural kind of connotation. It also, focusing on the fetus, has this implication of maternal worth, that women, when they're pregnant, they have access to better services. They have access to treatment and therapy, which I think those things in and of themselves are good. But if we focus solely on protecting the fetus and give her more services only when she's pregnant, there is the implication that her value as a woman is not necessarily adequate, and that she only gets the best care when there is a fetus in her. When we focus on maternal care, I think that I always will say with patients that, we've been making babies on this planet literally for 1 million years. And our bodies are really good at it. We have the DNA of 1 million years of women behind us. And so if we care for the woman, we give the woman what she needs to be as stable, as healthy, and as strong as she can, her body is almost always going to do what we have done for 1 million years. We just have to kind of get out of the way a little bit. So the stable mother, if the mother is stable, it's easier to have better child development as well. The stigma versus the science, again, mothers should be able to suspend all needs. The stigma is that all drugs are dangerous to fetuses. Now, and that maternal drug use is selfish, right? But the science, so this is a very dangerous statement for me to say, but that most illicit drug use offers minimal danger to the fetus. Is there danger? Yeah, there definitely can be. Is it good to use meth in pregnancy? No, it's not good. But when we look at the data around what are the most dangerous things in pregnancy, those actually kind of fall down the list. The environment of drug use is really what I find causes most risk to both the mother and the fetus. Tobacco use, we'll talk about that, poverty, unstable housing, infection, violence. These things statistically cause more risk to the woman and therefore the fetus. I just love this quote, and I always use it to maybe take a drink of soda. This is how I approach my most of my care. So women who are have opioid use disorder, these are not intended pregnancies. It is safe to assume, SUPW, sorry, I didn't change it. Substance using pregnant women do not intend to become pregnant. The identification of these women, particularly opioids, is very difficult. If a woman is using opioids and has her dose stable, you're not going to be able to tell, because women who use opioids, or really anyone who uses opioids, they're either, if they're overusing, they'll have the fatigue and the nodding out and but if they're underusing, then they're in withdrawal and then they look ill. And we'll talk more about that. But if they have their dose set at a nice rate, you aren't going to be able to tell. And there's really not any validated tools for screening other than alcohol. But a combination of really just talking to clients or patients and doing a drug screen. Barriers to care. There is just, I don't think I even have to explain the increased stigma that pregnant women carry other greater than their non-pregnant counterparts. They are profoundly afraid of judgment by their healthcare system. They're terrified of exposure. But I think more than that is, obviously I have an issue with access, which is where, as medical clinicians out there, we can really change that narrative and increase the access for women pretty easily. What I've been seeing in clinic as far as opioid use disorder in pregnancy is really most women don't even recognize the depth of their addiction or their dependence until they become pregnant. Because of the stigma and the social messaging that women get, a lot of times women will attempt to just stop using opioids before they come in to be seen. This will throw them into withdrawal. And the withdrawal symptoms can be really misleading for both the patient and for clinicians. It's super easy to miss. This is why conversations are so critical, because here is what the symptoms of withdrawal are on the left and pregnancies on the right, and you don't even have to study them because I went ahead and all of the ones that are on both sides are red. So if we perhaps have a patient who is having what appears to be hyperemesis, presents to the emergency room, she's given fluids, she looks just miserable. And so just the well-intending, emergency room provider maybe gives her some IV fentanyl or just because she's so profoundly uncomfortable or dilaudid and her symptoms resolve, right? Well, historically, we would have maybe thought, well, oh my gosh, all this hydration, these anti-nausea meds totally helped her. But what in reality is happening is that if she was in withdrawal, it wasn't your fluids and it wasn't your Zofran, it was your fentanyl. And so just having those conversations is so critical because it is so very profoundly easy to miss. I had to look these up when I started opiate versus opioid because the language is kind of slippery. I tend to use the word opioid, but there's just that information for you. So what risk leads women to opioid use? Well, this is all substance use, right? So we've got genetics, environmental though, availability, peer use, trauma, sexual abuse. 8% of the general population suffers physical or sexual abuse, but in the substance using pregnant women, it's 32%. Pregnancy is not protective of drug use. I think it's really important to remember. It is not protective at all. So when we talk about why are women using, I'm just going to back up here. This down here, right? This physical sexual abuse and trauma, history of victimization, the very chemical level, both fundamental pre-thought level in the brain, emotional and physical pain cannot be differentiated. But that brain knows that it wants that and needs that pain treated. And what we know about opioids, this is a highly effective pain medication, right? And actually, side note, that the clinical use of opioids is considered to pose minimal risk to the mother or the fetus. It has been back in the alphabet grading of meds, a class B, right? So if women, we have all of this, pain, they have this pain. I'm just going to back up here because let's say I had a broken arm, right? And if my arm is broken, the pain is just so distracting. I can't think straight. I can't function. I can't do my work, right? But if we do something to get that pain under control, then my brain space clears up and I can think and function, relatively normal. And usually it's, if you have a fracture, you're usually going to get maybe some opioid. The same thing happens with this, this pre-thought trauma in the brain, this unhealed injury, unhealed trauma. The brain is so busy fighting that pain that it can't think clearly. Opioids are classified as a sedative as one of their classifications. But people who have untreated trauma, when they take an opioid, because that pain is relieved, they are activated, they think more clearly, they're able to get a lot more done. And so what's really happening is these women are self-managing their mental health issues and mental pain. Mental health meds, by the way, decrease risk of negative outcomes for mothers and newborns. And that's a whole different discussion. But this is really what we're finding is that, or what I have found is that almost all, if not all of the women that I worked with, they are really just treating the unhealed injury from trauma. Screening and identification, this should be an antepartum. There's absolutely no way that we should be doing this for the first time in labor and delivery. I feel like if we don't do this antepartum, then we are really failing women. We are not giving them the opportunity for the appropriate care and treatment that they need. Okay, screening. I think this is probably, oh, this, you already seen this slide. It's the 2-for-1. So I have a 2015, the Journal of Pediatrics printed this study, and I'll kind of let you read it as we go. But essentially, there used to be historically in labor and delivery, we would do risk-based urine toxicology, right? So if they had poor prenatal care, history of drug use, that would trigger the urine toxicology. So when this facility, this was in inner city Chicago, right? So this is a pretty rough population. But when they went from risk-based screening to universal screening, 20% of the opiate positive tests were recorded in mothers without any risk factors. I think that this is critical for us to remember, because there's basically 20 women who in my mind, we have in a sense failed, because if we didn't give them that screening early in pregnancy, we didn't give them the opportunity to get the care that they needed. And then this comes up in labor and delivery, and suddenly there's, child protective services involved. They may lose custody of that baby. This drug screen, I don't know where you folks are in the country. I don't know where you are in clinical setting, but just, I put this up when I first started. There's the opiate assay, which I actually missed a really critical patient because it didn't screen for oxycodone. So just make sure that when you're doing screenings with drug screens that that you really know what is on your screen, or on your screening tool. And this study, by the way, I just want to bring up, I think the universal screening early in pregnancy is the way to go. Again, so that we can offer women the support and care that they need, that maybe they can't ask for. I think about back in the beginning when, you used to have to ask permission for HIV screening because it was so sensitive, right? But now it's just part of the deal, right? And so I think that we as clinicians, if we continue to push forward with universal screening as a community standard, it's just, again, it will just become rote. And I know that some of the greater organizations in Minneapolis here are starting to really do that. So the risk, opioid use in pregnancy, the risk, it's really hard to answer because of all the comorbidities that go along with it. 95% of these women are cigarette smokers. Polysubstance use, mental health disorders, poor nutrition, and everyone's favorite, the complex social problems. So when we look at what are some of the major negative outcomes in pregnancy, right? So here we have increased spontaneous abortion or miscarriage, stillbirth, preterm birth, low birth weight, SIDS. Every single one of these, cigarette smoking is it is a risk factor. but there is no opioids on here, right? Opioids aren't really connected to any of this stuff. By the way, I just want to throw this in here, that cigarette smoking with sudden infant death syndrome. If we could decrease cigarette smoking in pregnancy and postpartum, we actually could decrease the SIDS rate by 30%. And here's a little bit of data about neonatal abstinence syndrome. We talked about how NAS is not unique to opioids. And here you can see that cigarette smoking significantly increases NAS symptoms, hospitalization times, decreases the birth weight. So when we're talking to women, when we're counseling women, the most important thing, if they really, I mean, not that they don't really want to, but the most impactful thing that they can do to increase the health of their pregnancy is to actually stop smoking. Whether, and, this is the NAS with the, this is NAS with opioid dependency withdrawal, but it is also reflective of a lot of the data just around general smoking. So, moral of the story really is the more comorbidities means the higher risk of negative outcomes. So I've been talking a lot about the comorbidities and all this other stuff, but like what, and I think most people know this because, and this slide is because I felt like no one knew this when I started talking, right? So if I talk, opioids are fine, opioids are great. I'm not saying they're great, but they're safe in pregnancy. There's not a lot of information that shows negative outcomes. So what is the true risk, right? The true risk in pregnancy is withdrawal. Withdrawal is dangerous, extremely dangerous to both the mother, to the woman, and to the fetus. So the dangers of withdrawal to a woman are here. And death could be by overdose or by violence. And the dangers of withdrawal to the fetus. It causes, the withdrawal causes fetal hypoxia. And in a nutshell, what happens is withdrawal is so violent on the body. It's rarely lethal, but people really die from it. But I do hear over and over again, it didn't kill me, but I wish in the midst of it, I wish it would have, because it's so awful. And when a woman's body is in such distress, it starts to shunt blood away from the uterus and from the fetus, which causes hypoxia or low oxygen levels and can cause damage in that way, because the woman's body is trying to protect her. And sometimes there's just not enough resources to also supply things to the passenger. And this can be this can be major withdrawals, and this can also be just the roller coaster of withdrawal, repeated withdrawal, and use. So the dangers of continued illicit use is women will, they'll use and then they'll start to withdraw, and then like, I'm never using again, and then they go into withdrawal and then back up. It's just this roller coaster, right? And it makes the intrauterine environment so unstable. And I like to call them, or refer to them, kind of as microwithdrawals, right? So if I, like a small withdrawal, right? So it's if I like snap my finger in my arm, right? If I do it over and over and over again, eventually I'm going to get a bruise. Eventually the tissue is going to break down. Eventually I'm going to have a hole in my arm, right? And so the microwithdrawals are kind of similar. It's like, how many insults of the withdrawal can this placenta and fetus tolerate? We don't know the tipping point, right? And so the goal of medical intervention is going to be maternal stabilization and safety, which is going to therefore cascade into that stable intrauterine environment and decrease. And then we also want to decrease those comorbidities. Just checking the timer. Okay, perfect. Have we got any questions that have popped up? Okay. I'm just going to assume that this is good, right? So I do want to talk about the FDA, because there is no official FDA indication for MAT in pregnancy. But it is supported by these organizations and more, and is considered community standard. In 2016, the FDA did review and change their labeling for MAT, which I find absolutely amazing, that they are saying that methadone and buprenorphine that their intent was to appropriately inform prescribers about the risk of NAS without inadvertently discouraging treatment for pregnant women with opioid addiction. So essentially they're saying, we're not going to say it's okay to use it, but us not saying it's okay doesn't mean we don't want you to do it. So my thoughts on universal drug screening in pregnancy. Yeah, I think I touched on it. I'm a huge fan. I think that the power of the drug screen is amazing. We can identify women and get them care that they would have otherwise not had. I also think that follow-up drug screening for women who do have use disorders, regardless of the drug, can be really helpful. If they are, requiring additional care, then we need to do that, right? If they're not able to, to kind of stay on track and stay sober, then we need to kind of up our game and give them better services. I also think follow-up drug screens are great if they're negative, because that gives her credit for the hard freaking work that she's done, because we can give her all the meds in the world, right? She's the one who has to make those decisions every single day. And if there is ever an accusation that she is using illicit drugs and we have negative drug screens, it's moot. So Dr. Kaltenbach, I don't know if you're familiar with her. She is one of the leading experts in the country in drug use disorders and pregnancy, does a ton of work around opioid use disorders. She's brilliant. So like I said, MAT should be considered medical management to avoid fetal and maternal injury. All right, I'm going to jump now into the interventions. Like how can we treat these women? What are our options? What's out there? What works? What doesn't work? And I do, before I go into anything further, I have been very, withdrawal avoidance is critical. I think back in the day, before buprenorphine hit the market, I worked in a small community clinic in South Minneapolis, and women would come in frequently come in with drug use, like active opioid use, like IV heroin use. And it would take 2 or 3 days to get them into the methadone clinic. And it is in Minnesota, and I assume nationally, illegal for us to prescribe opioids to manage opioid dependence or opioid addiction, right? So I couldn't write her a script for oxycodone just to get her through to the methadone clinic. You can't prescribe methadone unless you carry a special license in a very specific facility. And so one of the craziest things that I think I've ever said in my life is asking women if they had a safe supply of heroin and if they had clean needles, because we needed them to keep using until we could get them into the methadone clinic. I don't know why that actually came out, but I just felt like maybe I needed to say it. But one of the things that often comes up is medical withdrawal. Like, can we stabilize a woman on something and then and medically withdraw her under careful observation? There is research out there that shows it can be done safely, but it's in a highly controlled environment, and it's very specific candidate selection. And so I argue, is this really replicable in general population, especially if you are working with women women who are deep into drug use don't have usually the most stable environments. So I argue that it's not a viable option, and I actually can, we'll talk a little bit, just briefly more. Naloxone. This is, the brand name is Narcan. So we don't usually want to use naloxone in pregnancy for someone who is actively using and is, though, indicated as a life-saving measure. There are people who, so the long-acting, no, I'm just going to skip that part. So Methadone is the historic treatment for opioid use disorders. The struggles with methadone is that women need to go to clinic or present to a methadone clinic every single day to get their dose. They can gain what they call takeouts if they have repeated negative drug screens. The goal, I mean, it's wonderful. It was amazing before buprenorphine hit the market. It still is amazing. It's a 27-hour half-life. So once a day dosing. And so just that steady known supply of the drug or the medication really decreases the maternal risk-taking behavior. She becomes stable. I had a lot of women on methadone. The biggest complaint that I had when a woman would transition from the illicit drug to the methadone is the two biggest complaints I would ever get were boredom, because she doesn't know what to do with her time because she's been chasing drugs for so long, and constipation. I mean, those are the complaints that I was getting. I mean, no one really wanted to go to the methadone clinic to get it done, but usually the benefits are really, really outweighed the negatives for those women. Methadone assisted detox. This is kind of very similar to that medical withdrawal, right? It was get women off opioids, no NAS, right? Again, this is somewhat fetal focused, right? Because it really pushes for the NAS. It does definitely put women at just terribly increased risk. The relapse rate is, the number that's usually thrown out is 90% relapse rate. It doesn't work. There's a physiological dependence of the opioid in the brain. And so even though she may have, just the physiological dependence in the brain. Methadone maintenance. This is what we used to use all the time. But the biggest problem for that, I do also a lot of work with outstate tribal nations, and there are very few, if any, methadone clinics outstate. These are in metro areas. So I would have, I worked with White Earth Nation and getting treatment onto their reservation. We used buprenorphine, which we're going to talk about next. But before that, those women had three choices, right? They had pregnant women, because there was no methadone access. And at that point, there was no real Suboxone or buprenorphine prescribers. There was few and far between. And so these women could either continue illicit use and their child would be taken by child protection. They could stop using altogether and risk killing their fetus, or they could continue using, have a home birth, and hope that the mom and baby survive. I mean, those were their options. There was no option for treatment for them, which brings us to buprenorphine. This has entirely changed the landscape. Buprenorphine can be prescribed In Minnesota, and I'm not sure if this is nationally, so I apologize. In Minnesota, anyone who has a DEA license, an MD, an NP, a DO, can take the course, depends whether what your licensure is, either 8 or 24-hour course, and become a prescriber for buprenorphine. Trade name that we usually throw around is Suboxone. It is a mixed agonist-antagonist opioid receptor modulator. So whereas so in methadone treatment, and I apologize, I realized I didn't describe the physiology of opioid dependency, which real quick, we all have opioid receptors in our brain. That's why we crave sugar. And with repeated opioid use, the brain recognizes all the opioid in there. And so it actually creates more receptors. And those receptors become loud and they become noisy. And even when someone has gone beyond the physical withdrawal symptoms, their brain is still screaming. I relate it to, like, you know, when the new fire alarms go off and those flashing white lights. It's kind of what's going on in the brain all the time, right? So folks have a hard time thinking, functioning, because it's just all that, or maybe they remember the Kmart blue light specials, right? That's just going on in there. And there is just this constant demand to feed that receptor. So when we use methadone, which feeds the receptor, it does leave the receptor open. So more opioids can actually go in and intoxication can happen. Buprenorphine, on the other hand, it's this mixed agonist-antagonist where it will stimulate the receptor and then cover it, right? So I always say it's like got a cap on it. So if other opioids are used, for the most part, the opioids will come in, hit that cap and bounce off. So the risks of overdose with buprenorphine, very low. I have 5 minutes and we're opening for questions. I'm terrified. Okay, so, and we can get this in the office, right? They do not have to go to the methadone clinic every day. They can go to their regular clinic. Oh, they can go see their OB, and the OB, if they have that waiver, can prescribe that medication. It allows women, it significantly increases access, as well as decreases stigma, because it can really make it part of it normal care. It also, and I think it also is comprehensive care. It also decreases, because compared to methadone, it does decrease NAS symptoms. So the newborn stays in the hospital less. But these both medications, you know, in context of comprehensive care, is so important. We can also prescribe Suboxone, or I'm sorry, that is a hard one to not use because everyone refers to it. The buprenorphine for a week, 2 weeks, up to a month, right? So it becomes a regular medication. There's also a long-acting injectable on the market right now, which I'm having great success with, once-a-month injection, which has been profound in both stability as well as decreasing that need for the daily medication, which can sometimes be really shame triggering. There's also concern about diversion. But one diverted dose of buprenorphine decreases 3 IV drug injections. So you've got these comments from Dr. Kaltenbach, but then also diversion. Yeah, is it perfect? No, but it potentially, I mean, I challenge, it could potentially be life-saving too. All right, here's the parts where I got to go fast. Sorry. MAT is not adequate for pain management for surgical and postpartum pain. These women often will need more pain medication because of the desensitized receptors. So as if you're a clinician or if you're supporting a pregnant woman, having this conversation and doing planning is going to be really important. Also, I think empowering women or giving women information that if their provider or the nurse on staff is not appropriately addressing their pain, they need to and they should ask for a different nurse or switch providers, because that deserves to be addressed. And they deserve full scope care, and that includes pain management. Breastfeeding, absolutely yes, absolutely, absolutely. The withdrawal in the newborn is not mitigated by the maternal medication use. By the way, there's not enough in the breast milk, but research does show us that that just the bonding and the skin-to-skin contact does actually reduce NAS symptoms in the newborn. And obviously, it's contraindicated with active illicit use. Where are we at? So if you still have uncertainty about the use of buprenorphine just in women who are pregnant, who are not pregnant, this is again, it's a little bit of an older study, 2003. We'll never do it again. They had 40 people who were heroin users. Half of everybody got what I call the Kumbaya treatment, right? So traditional therapy and treatment. Half of them got the buprenorphine. After 1 year, 80% of the patients with buprenorphine were still engaged in care. After 60 days, none of the patients who did not receive buprenorphine, none of them were engaged in care, and 25% of them were dead. There is no other area of medicine where this would be tolerated. This is when the stigma comes in that we are not supplying pregnant women, this care. I was supposed to do a little, there's some psychosocial stuff. I'm happy to share all of these slides. I've just really had a hard time deciding what to give you guys. But just a quick case study. 24-year-old woman, 4-year history of intravenous heroin use. Presents, we get a positive pregnancy test, unexpected, as we would expect. And what's your initial plan? Like, what's your plan of attack, right? And so, and I see that it's 5 minutes, but I'm just this little thing. I think I have 2 slides in one in this next slide, but I think we can still read it. Like, what do we do, right? Oh my gosh, Elaine, if you can't read that. Like I was like, I feel like I'm missing something on this slide, right? Like, what do I do? But basically stabilize her. She's going to probably need education about withdrawal avoidance. We do an induction onto buprenorphine or methadone. We get her, or if we aren't doing it, we need to get her to someone who can right away, right now. Right? So we stabilize her. Then we assess her and treat her health through lab values, right? Prenatal screening, including hepatitis C. Hepatitis C is rampant in the IV use community, right? So there we go. We're getting the labs done. Got to figure out how pregnant she is, because that's going to make a difference for what kind of care we supply. We assess and treat or refer out for her mental health needs. And then does she have comorbidities? Is she a smoker? Does she have a place to live? Is she trading sex for a place to sleep? And get her the psychosocial connections so that those things can be addressed, because one of the leading causes of relapse is actually no housing. And so this is like my slide. I'm like, I feel like I'm missing anything. And if there's any other clinicians out there, it's like, it's just really, frankly, it's just really not hard. It's just maybe one more step in getting her stabilized. All right, that's what I have. Any questions?
Yeah, it looks like we have one question here. The comment was, this is eye-opening, and I wonder if we as a field are spending too much focus educating women on the negative effects of drug use on the fetus and should instead be focusing on withdrawal effects, particularly NAS.
I think what we need to do is talk about really what's dangerous and what's not. You know, the two most dangerous drugs in pregnancy are going to be number one, alcohol, and number two, commercial tobacco or cigarettes, nicotine. So vaping now is a big deal. But I don't think, quite frankly, we should be focusing on either of those, because both of them feel, just real frankly, very fetal focused again. And while the fetus, I mean, okay, I don't want to pretend that the baby's not important, right? It's very important. We need to monitor, we need to do that. But if we take a step back and we focus on maternal health and need, and that stabilization, treat her as a woman and not an incubator, the cascade will happen for a stable fetus. Is NAS a risk? It is, and we need to discuss it. At the same time, if we don't treat women in pregnancy for opioid use disorder, the alternative is fetal death. And potentially, or, you know, losing her baby to child protection. One of the most horrible days I ever have had in clinic is I've had many women who get pregnant stop using, because that's what pregnant women are supposed to, like, stop everything, right? And they come into clinic just for me to be able to put an ultrasound on their belly to tell them in a kinder, gentler way. But that act of loving kindness that they did for their child actually killed them. So accurate data, that's what we have to do. We have to care for women and let the cascade happen and support that cascade.
Thank you so much, Amy. As always, very informative presentation. I know that we kind of ran out of some time here. We're right at 1 now. So I think I'm going to close things up. Just to let everybody know about our upcoming MIH session. That's going to be March 16th. That's our next one. And it's going to be presented by Dr. Cresta Jones. And the topic will be on prenatal substance use and reporting laws. So look forward to that.
I also wanted to add in, we've been talking about MAT services. That has come up a lot, that Wayside is hosting a MAT boot camp April 21st, and also a DEA waiver training the 22nd. So if you all are interested in learning more about MAT services, the benefits of MAT services, what that looks like, I would encourage you all to register and sign up for that to see how we can support our communities who may be needing those services and those resources. You can find that on our website as well. Again, oh, go ahead, Amy.
Feel free, please, to reach out if you have any questions. If you want a slide deck, I can give it to you I will share without hesitation.
Perfect.
Awesome. Yes, we would love that information. We will be sure to send out Amy's information along with her slides if she is willing to share those. And then also be looking out for surveys that should be coming out to each of you. We really value and appreciate your feedback, as well as we give it to our presenters as well, to give them just feedback and make sure we are on the right track and providing you with good information, resources, all of those great things. So once again, Amy, thank you for all of your wealth of knowledge, for bringing this topic to the table, for your time, your energy, all of those great things. And also shout out again to our sponsors, DHS, for hosting this event, and all of you who signed up and are in attendance today. Any last closing remarks, any last questions? All right. Well, thank you all.
Oh, I do actually. That's my personal cell phone number. So for anyone here, feel free to use it. just maybe don't give it to your clients or patients. So that'd be great. Be great.
Awesome.
I'm working on boundaries. So
Well, thank you all. We look forward to working with you again, Amy, for sure. And also look forward to everyone who's in attendance and coming back to attend our MIH Echoes or other sessions that we have available. Hope you all have a great day, a good rest of your week, and we'll be seeing you soon.